We're staying on the RSV topic, and our next speaker is Gemma Saravanos. Gemma is a researcher from Sydney.
Good afternoon, and thank you to the Immunisation Coalition for inviting me to talk with you today. My name is Gemma Saravanos. I'm an academic fellow and associate lecturer at the University of Sydney, Susan Wakil School of Nursing and Midwifery. I've also got a postdoc appointment as a research fellow at the University of Sydney Children's Hospital at Westmead Clinical School. I'm excited to be here today to talk to you about RSV epidemiology, and I've titled the talk today, A Journey Through Time. We'll start our journey in 1956 when RSV was first discovered. I'll then provide an overview of the distribution and determinants of RSV disease, discuss some of the more recent literature showing the impact of the COVID-19 pandemic on RSV epi and what has happened since. I'll finish up with some of the other considerations needed as we prepare for RSV-specific prevention using vaccines and monoclonal antibodies. In particular, I'll focus on RSV surveillance and addressing gaps in disease burden estimates. RSV was first identified and described in 1956 when it was recovered from a snotty chimpanzee, and it was given the name chimpanzee coryza agent. The virus was later renamed as respiratory syncytial virus as it caused the formation of syncytia in cells or giant multinucleated cells seen here in this old cell culture micrograph. Robert Chanek is credited for identifying and establishing the link between the virus and large seasonal epidemics of childhood respiratory infections, in particular bronchiolitis, and he did an impressive volume of work in this area. In 1961, the first report of RSV in Australia, Melbourne, was published in the Medical Journal of Australia. It was also established early on that RSV infection doesn't result in sterilising immunity, and that reinfections occur throughout life, but subsequent infections are typically milder. Transmission of the virus is predominantly through droplet and contact routes. However, there is some evidence for aerosol transmission. Characterising the full burden of RSV disease is increasingly important as we approach RSV-specific interventions such as vaccines and monoclonal antibodies. Overall, the highest burden of RSV disease occurs in children aged less than 5 years. It's the leading cause of severe acute lower respiratory tract infection in this group. RSV mortality can and does occur in community and in hospitals, mostly in low resource settings in and at risk groups. Hospitalisations and ED presentations are predominantly due to respiratory infections, but exacerbation of chronic conditions, so think about things like chronic obstructive pulmonary disease in adults, as well as extrapulmonary presentations such as seizures are also important. Community disease is less well characterised and may have a range of presentations including mild upper respiratory tract infection and otitis media. Community RSV disease is also a big driver of antibiotic use. Global burden of disease estimates have been published in recent years. However, these are likely to underestimate the true burden of disease, particularly so in low resource settings where there's limited data and higher risk of poor outcomes such as death. Also highlighting here the generally large uncertainty range of these estimates. We have some excellent research in Australia to inform on the burden of disease in children, but I will note that this is currently limited for adults in the Australian population. Community disease was nicely characterised in an Australian birth cohort study from Queensland. This study found that most children are infected with RSV by around 2 years of age, and roughly 1/3 of these children with an RSV infection will seek community medical care. Around 2% are hospitalised. Bronchiolitis is the leading cause of ED presentation in children aged under 1 year and the leading cause of non-elective ICU admission. And we know that the majority of bronchiolitis is due to RSV infection, around 50 to 80%. RSV-associated hospitalisation rates in Australian children are high, and about 45% of all hospitalisations occur in infants aged less than 6 months. Existing estimates likely underestimate the true burden of disease, however. In our study, we found that Aboriginal and Torres Strait Islander children were almost twice as likely to have an RSV hospitalisation compared to non-Indigenous children. RSV epidemics also present a significant economic burden. An RSV hospitalisation for a child in Australia was estimated to cost over $6,000 and around $20,000 for an ICU admission. Finally, RSV attributable deaths are likely to be infrequent, but in our study we found that they do occur in certain high-risk groups, such as children with immunosuppression and chronic neurological diseases. The numbers don't provide the full picture, and I would like to share with you the story of Oscar, who came to our hospital in the winter of 2022 with RSV bronchiolitis. Little Oscar was just 2 months old when he first encountered RSV, and he presented to his local hospital for care. When he continued to deteriorate, he was transferred by the Newborn and Paediatric Emergency Transport Service, also known as NETS, to the Sydney Children's Hospital in Randwick, and he was found to have a partially collapsed lung due to severe coughing episodes, and he required 6 days in the ICU with ventilation support. Thankfully, Oscar made a full recovery, and you can see his pretty happy looking little face there on the right-hand side. But you can start to imagine the significant impact of this stressful event on Oscar's whole family. And I'm thankful to them for sharing their story to raise awareness of what severe RSV disease can be like. Young age is the single most important risk factor for severe RSV disease, and this is reflected in the distribution. But there are a range of other factors that can contribute to the likelihood of and distribution of severe RSV disease, nicely shown in this image. These include factors such as climate, air pollution, older age, the presence of certain comorbidities, immunological features, and also viral features such as circulating subtypes and genotypes. Accurate disease burden estimates are essential for setting vaccine policy and are needed to support recommendations for high-risk groups, as well as vaccine target groups. For example, pregnant women who might receive maternal vaccination to prevent severe RSV disease in their infants. There are a range of groups in the Australian population and global population where there's currently limited data. These include adults generally, Aboriginal and Torres Strait Islander adults, individuals with comorbidities, patients at risk of healthcare associated infection, atypical presentations, regional and remote populations, and low resource settings. Many of these gaps apply to an extent to other vaccine preventable diseases such as influenza and COVID-19. So it's important to consider how we can modify existing systems to collect data on some of these things like pregnancy and comorbidity. So now let's look at the seasonality of RSV epidemiology before COVID. This map provides an overview of the predicted global prevalence of RSV and flu by month based on data from 2000 to 2017. This study found clear seasonal RSV epidemics occurred in both temperate and tropical regions, starting in the late summer months in the tropics, reaching most temperate sites by the winter months. This study found that the RSV season typically preceded the influenza season and had a duration of roughly 4.5 months. If you just focus on Australia, RSV in Australia in the top graphic there, you'll notice that there is significant variation by region within our country. Now looking at RSV hospitalisation rates from each Australian state and territory, these figures once again here show that strong seasonality of RSV disease across most of the population of Australia. The Northern Territory is an obvious outlier, and in tropical regions such as the top end of Australia, seasonal patterns are less well defined. And this has implications for planning the delivery of prevention strategies in these areas. This is nicely illustrated in this study from Hogan and colleagues in Western Australia, which includes both temperate and tropical regions across a large landmass. They used a time series analysis to describe RSV seasonality across Western Australian regions using 13 years of laboratory and hospitalisation data. They demonstrated clear winter epidemic peaks in southern Western Australian regions, but less identifiable seasonality in the northern regions. See at the top there, these figures from the Kimberley and Pilbara region. Despite some challenges with defining disease burden and seasonality, things were going quite well with regards to RSV research and surveillance development. Then along came COVID-19 and we saw the rates of infectious diseases, including RSV, plummet. This is a figure from a study undertaken at the Sydney Children's Hospital Network using data from the years 2015 to 2020, and it shows the expected and the actual counts of RSV-associated disease in 2020 and prior years during typical peak seasons. So that's capturing data from April to June. In this study, we found that laboratory detections were 94% lower than predicted, bronchiolitis admissions were 86% lower, and ED presentations for acute respiratory infection were 71% lower than predicted. Another interesting thing that coincided with COVID restrictions was a marked reduction in the genetic diversity of RSV, shown in this study by Eden and colleagues. Australian RSV specimens sampled before March 2020 were distributed amongst those circulating globally. If you see the red dots, these indicate New South Wales samples, and you can see that they're distributed throughout this phylogenetic tree. Following the COVID-19 lockdown, two geographically distinct virus clades emerged. One was associated with cases from New South Wales, ACT and Victoria, while the other was associated with cases from Western Australia. As we've seen with SARS-CoV-2, this viral genetic information may have important implications for disease transmission, severity, and also vaccine effectiveness, so we need to closely monitor these types of changes. Unfortunately, as you know, RSV came back with a vengeance. RSV laboratory detections skyrocketed, as seen here in this figure by Foley and colleagues from Western Australia. Looking at RSV-associated hospital admissions rather than laboratory detections presents a slightly different picture. Our study from New South Wales examining RSV-associated paediatric hospitalisation reflected the out-of-season pattern, but actually didn't find a statistically significant increase in the number of hospitalisations when compared to previous years. We did, however, find evidence of increased RSV infections and increased peak hospitalisations, and we found that these were concentrated in older children. Overall, various studies from Australia and abroad reported atypical epidemics characterised by out-of-season increases in RSV infections and peak case counts, a shift in the age distribution of RSV disease, particularly towards older children, a shift in the distribution of the clinical phenotype of RSV disease, likely reflecting that shifted age distribution. So, for example, many sites saw similar numbers of bronchiolitis, but greater numbers of things like RSV-associated wheeze and other acute lower respiratory infections, and also neurological disease. The majority of studies have found limited evidence for changes to RSV disease severity. These trends played out across the globe, each country with their own nuances with regards to study methods and potential confounders, making comparison quite difficult. Studies consistently reported shifts in the age distribution towards older children. Some studies did report overall increases in hospitalisation, including for children aged under 3 months, and this was hypothesised to be due to reduced maternal RSV exposure. The best near real-time data that I can find from Australia is captured by the New South Wales Public Health Rapid Emergency Disease and Syndromic Surveillance, otherwise known as the FREDS system. We know from previous studies that the syndrome bronchiolitis is a good indicator for RSV infection. These data show bronchiolitis ED presentation trends for the last 6 years. And it's interesting to note the high peak of presentations in 2022 in the black line, which wasn't seen in 2021, that atypical season, and that's in the purple line there. These data are very useful to inform on RSV activity, but they must be complemented by other surveillance systems in order to be able to interpret them completely. Finally, 60 years after its discovery, RSV was getting some media attention, but was for all the wrong reasons. In June last year, we had an urgent warning to Aussie parents about a killer virus, and we can thank America for bringing us the term triple-demic to describe the coinciding epidemic of flu, RSV, and COVID in the Northern Hemisphere. It's widely agreed that the cause of these atypical RSV epidemics are due to COVID-19 pandemic restrictions and non-pharmaceutical interventions. This has led to reduced exposure to RSV infections, both primary and repeat infections, leading to reduced population immunity, likely across all age groups. It's also important to note the changes in RSV testing practices, which have likely contributed to higher case counts, as well as changes to models of care and healthcare seeking behaviours, which may affect our disease estimates. A figure from this study, which demonstrated a reduction in antibody levels and neutralisation titers in women of childbearing age and their infants about 1 year into the COVID-19 pandemic, nicely highlights the reduced immunity in these two population groups imposed by the pandemic restrictions. I really like this visual explanation based on modelling from Messakar and colleagues. The top section of the figure shows the trend of viral illness over time during the pandemic period, and the bottom section of the figure shows the trends of susceptibility in the population, creating what has been termed an immunity gap. They highlight that this has particularly increased the population size of older susceptible children who may have skipped an early RSV infection, and possibly a group of children who might have waning immunity and might be more susceptible to severe disease. The authors of this study concluded that epidemiological modelling of the disrupted circulation of endemic viruses in children and the resulting immunity gap suggests that healthcare systems must prepare for further uncertainty, including the possibility of larger outbreaks occurring out of season among children, among older children, and with atypical presentations. Preparedness for future RSV epidemics, whether predictable or atypical, depends on improved real-time pathogen and syndromic surveillance to provide early warnings to healthcare systems to support the public health response. We are very well placed in Australia with regards to developing robust and sustainable RSV surveillance systems. There are a lot of high quality platforms and networks that could contribute to RSV surveillance initiatives. RSV has recently been made a nationally notifiable disease, which is great news. Australia is involved in the World Health Organization's RSV surveillance pilot program, and we have some excellent syndromic and clinical surveillance systems, such as flu tracking, ANZIX and PEDS, and also aspirin. We also have the government's promise of an Australian Centre for Disease Control. What we are missing is the coordinated integration of these systems, coupled with innovative approaches to use routinely collected data to complement more intensive surveillance for a range of pathogens and syndromes. We also need to address those gaps in disease burden estimates by investing in high quality research in order to realise the full benefit of RSV specific prevention in children, older adults, and other groups who might be at risk of severe RSV disease. I'd like to thank you for your attention today, and I'd also like to acknowledge my collaborators at the University of Sydney and the Sydney Children's Hospital Network, in particular Associate Professor Philip Britton, who leads the Centre for Paediatric Infectious Diseases Research.
Gemma, hi, thank you. That was fabulous. Can you hear us?
Hi, I can hear you coming through loud and clear.
Terrific. So there's a question from David Smith.
Thanks, Gemma. That was great. A couple of comments, because we did the RSV genomic study with our colleagues in the East Coast. One thing is this sort of statements you made that RSV normally precedes the flu season, and it sort of creates this idea that it's a harbinger of flu. But in fact, what happens is RSV has always been exactly the same time every year, and flu moves around, and occasionally it's before, and occasionally same times, and occasionally after. So I think there are different drivers, which is really important because there's opportunities to look at what might be different about drives and behaviour of those two different viruses. Metapneumovirus showed the similar changes in its both its genetic diversity and its epidemiology, but with a slightly different epidemiology from RSV, and we haven't yet looked at the ones that didn't change, like adenos, and I think rhinos didn't change. So I think these are great opportunities to learn a lot more about what's driving behaviour when we've had this huge natural experiment happen. And also the other issue is better tracking where it comes from, which might understand what the drivers of the different activity are in the north of the country as well. So I think it's all wonderful stuff, and but I think we have a lot more to learn about what drives most of our respiratory viruses. But you're sure, I'm sure you'll have some views on that.
Yeah. What are your thoughts, Gemma?
Look, I mean, absolutely, wholeheartedly agree with everything you've said there. Thanks for the comments, David. Yeah, I think we've learnt a lot very quickly about a lot of respiratory viruses, but I think in many ways it's uncovered so many things that we still don't fully understand. So understanding, the transmission dynamics and those drivers of transmission is really a really important area, which I hope, in the near future we will learn a little bit more, particularly with regards to RSV and flu and these other viruses that we have interventions that we can, do something with.
Gemma, in older adults, the more we look, the more we find, particularly with increased testing. Is there a relationship between older adults and young children in terms of pools of the virus and spread of the virus and the lack of virus with lockdown?
Yes, there's certainly a relationship there. I mean, I think there's a lot of good studies done quite early on that suggested that younger children and preschool-aged children might have been the drivers for transmission and for driving epidemics. I haven't, and I'm not aware of a lot of good studies really unpicking this, in more recent times. And I think this is another area that we could definitely come to grips on better to understand. Certainly the increased proportion of older kids with RSV infection was really quite interesting, but quite difficult to unpick what's actually going on with regards to transmission.
Is there an argument to vaccinate grandparents to prevent spread to their newborn grandchildren?
Yeah, I guess that depends on the efficacy of the product to actually prevent that transmission, which is something I don't know if we've really got that information yet. Look, I think that's certainly something to consider.
David?
Thanks. We've looked at several years of the typing and whole genome sequencing from adult cases as well, which we get through the year. And not surprisingly, what you find in the adult population is pretty much what you find in the kids, with slightly different EPIs. There can be slight delays in either the subtype and possibly the strain which appears in adult populations and kids populations, which presumably is a driver of what they've had different exposures and different selection of strains. But there wasn't any obvious thing on a gross epi scale that says it comes into all the children first and goes into the adults, or vice versa. It all seems to happen at the same time. And indeed nothing that would suggest that vaccines would be any differently effective in the kids and the adults at any one season.
Thank you. Any other questions or comments for Gemma? Gemma, terrific work. Keep it up. Thank you.